Hey, good afternoon, everybody. Thank you for joining us for ATI transplant rounds today. I'd like to start with the acknowledgement that the University of Alberta is located on Treaty 6 territory and respects the histories, languages, and cultures of First Nations, Métis, Inuit, and all First Peoples of Canada, whose presence continues to enrich our vibrant community. I'd also like to thank Paladin for the support and remind you of our urge to have you all register for our ATI Research Day that's coming up on March 26th. So please register if possible. Next week's seminar series may or may not occur. There's trouble with the current speaker, so we're looking into a replacement. If not, you will hear that it does not occur. Before I introduce our speaker today, Dr. Jon Kobashigawa, I would like to take the opportunity to commemorate a shared friend, Dr. Jignesh Patel, who has been working for many years with Dr. Kobashigawa and has been an absolutely instrumental person in driving forward HLA management in heart transplantation as well, and has always been a very open ear and valued discussion partner for complicated patients, and sadly passed away recently. Today, we have the honor and pleasure to have one of the, without exaggeration, legends of heart transplantation and transplant immunology speak to us. Dr. Jon Kobashigawa is Thomas D. Gordon Professor of Medicine at Cedars-Sinai and serves as Director of Advanced Heart Disease Division and Director of Heart Transplant Program there. He's past president of the International Society of Heart and Lung President, past ISHLT Program Chair, past chair of the ACC and AHA Committee on Heart Failure and Transplantation, past member of UNOS committees, and currently the president of the American Society of Transplantation. With over 400 peer-reviewed publications, he's very highly recognized and prolific, and this includes many collaborative work groups and over 70 national and international consensus conferences that he organized on the topic, on many topics, but most recently, again, an update on antibody management in heart transplantation that is just being published or just being accepted for publication with a great collaborative effort. And he will update us today on HLA antibodies in heart transplantation. It's my great pleasure to hand over to Dr. Jon Kobashigawa. Thank you.
Well, thank you so much, Dr. Urschel. It's a pleasure to be here, and thank you for your very kind words about my colleague Jignesh Patel. Jig was a very close colleague, dear friend, and certainly contributed greatly to the field of transplantation, and particularly to the HLA field as well. So again, I thank you for those kind comments. So I'd like to speak on today on update in HLA antibodies and talk a little bit about what we came to conclusions in terms of our consensus conference that was held 2 years ago. And now the paper is actually just coming out at this point in time. So we'll get right to that. But let me give you some preliminary discussion as well. But here's my disclosure. I will discuss off-label use of investigational medications, including daratumumab, eculizumab, teclistamab, and I do have relationships to disclose research grants with Novartis, CareDx, and Sanofi. Let me just start with a case study. This is an example of a broadly sensitized patient with only a single C1q binding antibody, status 4, which means not urgent status, but stable left ventricular assist device patient, which is very common in the United States. Now, in this picture here, this is a 68-year-old female on the heart transplant wait list. She's 5'6", 5 feet 6 inches, weight 195 pounds, blood type O, again, status 4 with a left ventricular assist device. What you see on the right-hand side are these colors. These colors represent the undiluted, or we call neat specimen. And this gives you an idea that this patient indeed has a lot of antibodies, is broadly sensitized, and has some very high level antibodies, binding antibodies, in the greater than 10,000 MFI range. Now, in yellow, you represent a calculated PRA of 83%. That means that, again, 83% of the potential donors out there are not compatible. If we move that threshold from any detection up to 5,000, greater than 5,000 would be avoids, that moves the CPRA down to 74%. So it does widen the donor pool as we avoid less antibodies. And if we go less than 10, greater than 10,000 to avoid, that CPRA goes to 61%. So, it really does make a big difference as to what you set your threshold in terms of avoid, and hence the CPRA. And I'll talk a little bit more about that too. Now, we always do, whenever we have high-level high-level antibodies greater than 10,000, we automatically do a 1-to-8 dilution, and that's in the middle row that you see there. And that, you see, takes out a lot of the antibodies. So a lot of these antibodies that are present in the undiluted specimen, once you do a 1-to-8 dilution, a lot of them drop out. In other words, they're not as many antibodies there as we think. And in fact, the 1-to-8 dilution, when you look at the CPRA, comes down to 54%. Now that means our threshold here is any detection of any antibodies in the diluted 1-to-8 assay. Now, you go down to that bottom row there, and that's the C1Q. This is our functional assay where we see whether or not these antibodies can bind complement and hence potentially, and I'll use that word carefully, potentially cause killing. And that brings it down to 48%. And what it is just representative of one antibody, actually, an HLA-A2. Now you say, well, why is that so high? It's because it's very common in many patients in the community, or many people in the community carry that HLA-A2, and hence 48% of the community may have HLA-A2, so they're not going to be compatible if we make this an avoid, and certainly we would in our situation. So what is your approach to this patient? Any avoids or desensitized? And this is actually from the consensus conference that we had. We queried 6 centers from literally around the world to see what they would do. And I just show you this because there are many ways to treat these patients and to, approach them in desensitization. The groups were Vanderbilt Peds, St. Vincent's from Australia, UNC, University of North Carolina, Hamburg from Germany, and Cedars-Sinai. So what would Vanderbilt do? Well, they would use plasmapheresis, IVIG, bortezomib, avoid A2. And I think all of the programs would avoid the A2, but you see, because of the broadly sensitized case, you see something different from each program. The Vanderbilt Peds group, IVIG and rituximab, St. Vincent's, they would avoid A2, but if the antibody developed post-LVAD implantation, they're not concerned about it. They wouldn't do anything more because the antibodies may decapitate, meaning decrease following LVAD explant. I'll talk a little bit about that too. UNC would avoid A2 and not much else. Hamburg would avoid antibodies greater than 10,000 in addition to the A2, and they would do perioperative plasmapheresis. And what would we do at Cedars? Well, we avoid the A2, and essentially we would probably not do very much. We might consider eculizumab if we're crossing any very high level, meaning greater than 17,000 strong antibody, donor-specific antibody. And I'll talk a little bit about that, but I just show you this case example to show that there are many different approaches in terms of how one may approach these antibodies. And there's no resolution to this yet, mainly because there are no big, long studies, large studies that actually show a benefit one particular strategy over the other. All right, so let me get right to sensitization. In patients awaiting transplant, it's due to circulating antibodies developing from prior blood transfusions, mechanical circulatory support devices, and pregnancy. Sensitized patients have an increased risk for rejection, severe rejection, which we call hemodynamic compromised rejection, cardiac allograft vasculopathy, and mortality. Heart failure patients who require MCS implantation appear to be at special higher risk for sensitization. But does it make a difference? And I'll talk a little bit about that down the lecture as well. And so why are we so worried about this sensitization. Well, there's a study that was done by my colleague, Evan Kransdorf, and basically he looked at CPRAs. And as you can see, the higher the CPRA, meaning the more potential donors that are not compatible, you're going to wait longer. And this study, as simple as it may sound, actually demonstrated just that. That when you go from control, no PRA, your average wait time is 59.2. Now, these are all comers in the UNOS registry. When you have a CPRA of 80 to 100%, you're going to wait 202 days on the average. Now, the longer you wait on the wait list, the more chance you have for decompensation, for complications to occur. And that's why waiting on the list too does have some issues in terms of having complications and maybe even getting worse and not making it to transplantation. All right. So what about the approach to the antibody detection? What do we use moving forward at this point in time? Well, we have the ability to identify using the Luminex single antigen bead platform that determines the specificity of the antibody. We can measure strength of binding. The Luminex with flow cytometry and immunofluorescent measures the amount of binding of antibody, again known as the mean fluorescence intensity, MFI. We can assess function, and here at Cedars we use a C1Q complement binding assay. I know that there are others. And this assesses for the presence of antibody with the ability to bind a complement and the ability to protect, perhaps, injure the donor organ. And so what do we use as being significant? In our program here, a mild reactivity would be less than 5,000 MFI, moderate 5 to 10,000 MFI, strongly reactive greater than 10,000 MFI. And this has been up for discussion though too, in terms of maybe we're being a little bit too conservative here as well. But we'll talk a little bit about that to come as well. And so I would like to talk about some definitions because I think that's really important, just so that we're all on the same page. We do use a virtual cross-match, and this is a solid phase. Assays have been used to predict compatibility of donor organs by comparing the potential recipient's HLA specific antibodies with the HLA type of the prospective donor. So we do this matching to see whether or not we have high levels of antibodies against any specific donor. And this is the approach that we call the virtual cross-match. Now, the virtual cross-match negates the need to send recipient blood to organ procurement organizations for a prospective cross-match, thus increasing the donor pool, because you can't send blood to every, OPO, in your surrounding regions, your region, your surrounding regions. And so it makes just a lot of sense that if you have high levels of antibodies against a specific donor, you will avoid that donor because you have your patient has high antibodies against that donor and may cause hyperacute rejection. So, and that's why this virtual cross-match is so easy in the sense of use. But it's important because you have to designate what your threshold, what your level of acceptance is in terms of accepting donors at low level of MFI, medium, or high level of MFI. We'll talk about that as well. And that's how we actually come to the calculated PRA. The CPRA, calculated PRA, is a percentage of donor hearts in a given population to which a heart transplant candidate has significant anti-HLA antibodies. The corresponding antigens to these antibodies are deemed unacceptable, and those potential donors with these unacceptable antigens are automatically turned away by the UNET computer. So basically, it's a computerized system that if you say that you have high antibodies against HLA-A2, and you will not accept any donor with HLA-A2, so all these donors with HLA-A2 won't even be presented to your recipient. The threshold MFI to determine when an anti-HLA antibody is to be avoided is defined by the heart transplant program and is dependent on antibody strength. And so that's really the MFI we're talking about. In our program here, we will use up to 10,000 MFI as a threshold to avoid for patients who are highly sensitized. And I'll even go to that even further in terms of what we might do for the highly, highly sensitized patients. Many programs in the country will say any detected antibody, meaning greater than 2,000, whatever the lower level of detection is, will be their avoid. So you're avoiding a lot of potential donors in that case. Many programs will use 3,000 MFI, 5,000 MFI. And as you can see, as you go further up, in terms of, higher thresholds, you actually enlarge the donor pool because you're avoiding less, patients, less antibodies and less donors in that light. So the higher the CPRA, the harder it is to find a suitable donor. For example, 70% CPRA means that 70% of donors will be automatically turned away. All right. So these are the important concepts as we move forward. I show you this slide just to give an idea of what we do at Cedars, determining the CPRA for the virtual cross-match, single antibody assay for specificity, the Luminix platform. We determine MFI thresholds. In this case, let's say 5,000, and that's what most programs do around the country. Perform a dilution assay in C1Q when appropriate, if you have a lot of antibodies in high levels. And then we enter unacceptable antigens into the UNOS calculator. Now, again, we determine here that it may be 5,000 MFI, but because of what we do at Cedars, we may actually just avoid only those antibodies that are C1Q positive. In other words, only avoid those antibodies that have potential to injure the donor heart. Well, what does that mean? Well, that means that we're going to be crossing high levels of DSA, and that is a challenge by itself, and something that we do take into account where we may use other strategies, and I'll get into that as well. And so once we put in your avoids, you obtain a calculated PRA that's determined by the UNOS calculator and based on these unacceptable antigens. So again, it really depends on what you set your threshold as in terms of whether your donor pool will be larger or smaller as you avoid more and more antibodies. All right, well, let me get right to several issues here. These are the clinical challenges in the sensitized patient. If circulating antibodies are detected in the pre-transplant patient, when should one intervene? What can be done to lower these antibody levels? Does lowering the antibody levels make a difference in clinical outcome? How do you treat pre-transplant desensitized patients after heart transplant? And how do you treat post-transplant donor-specific antibodies that pop up that may be asymptomatic? If they're symptomatic, then I think everybody would treat, but what do you do about those asymptomatic patients? And I hope to answer some of these questions as well. And to do that, let me turn to our ISHLT consensus conference that we held in Denver, Colorado, April in 2023. So that literally was 2 years ago. And this consensus conference included 52 US and 23 international multidisciplinary experts in cardiac transplantation and transplant immunology. So this was a large number, 75 people who were involved in this conference. So what I'm going to do for the next several slides is show you some concepts that came out of this conference, and basically they are the consensus statements. But the first one has to do with risk. And it was felt by the participants that we should stratify the antibody risk by MFI in the undiluted assay. And we switched it around because many thought that greater than 10,000 was taking too much risk, and that 8,000 was actually a better reliability for risk in terms of antibodies causing damage or injury to the donor organ. Low risk would be less than 5,000, moderate risk would be 5,000 to 8,000, and high risk would be greater than 8,000 MFI. Now, there would be other factors to stratify antibody risk, and that includes the HLA locus, the strength in the dilution assay, complement binding assay. When we talk about the strength in the dilution assay, I think you all know that is the poor man's C1Q in essence. The higher the antibody MFI in the dilution assay, the more likely that it may actually cause killing by binding complement. Because not everyone, not all programs have a complement binding assay, but using the dilution may be just as well. There are clinical factors such as urgency on the wait list status, patient comorbidities that may make you be more open or making your threshold higher, so you expand the donor pool if you have somebody who's really sick, who really needs a donor organ as quick as possible. Center support, expertise in managing antibodies. It's your HLA lab, very supportive, doing retrospective cross matches, prospective cross matches, and the infrastructure, the HLA laboratory capabilities, as we talked about before. All right, now what about the next topic of desensitization? Well, at that point, the participants felt that we would consider desensitization of the CPRA is greater than 50%. Now, what threshold would that be? Well, many thought that it would be 3 to 5,000 in terms of a threshold, depending on the patient antibody characteristics and center support infrastructure, as we talked about before. The goal of pre-transplant desensitization therapy is to lower the CPRA to broaden the donor pool and minimize the risk of post-transplant antibody-mediated rejection. Now, common desensitization therapies include combinations of the following: plasmapheresis, immunoabsorption, IVIG, rituximab, bortezomib, all of that you saw, when I presented that case study in terms of what others would do as well. There were some issues with pediatrics, and Lori Weiss and Simon Urschel played a role in this. There is a need for precision in defining ABO-related histocompatibility between donor and recipients to enable clinicians to carefully analyze risk and benefit while expanding this platform from infants to older children and select adults. Yes, adults as well. HLA DSA before and after transplant are of clinical relevance in pediatric patients similar to adults. However, the extent, impact, and approach may be different, especially given similar early outcomes for sensitized patients and patients with a positive cross-match. So there are issues with the pediatric patients that are different from the adults. Moving forward to talk about crossing DSA at transplant. As you can see, with the higher the sensitized patients, you're going to cross DSA. Virtual cross-match might not be applicable to patients with complicated interpretations of HLA antibodies, for example, multiple lower-level DSAs. If you have cross-reactive epitope groups, for example, they may actually harbor the same epitopes, so you can actually stack those up, and they'll be much higher. So one has to be careful about when you look at epitope groups as well, and thus a prospective cross-match may be warranted in those type of patients. Crossing DSA in experienced centers may be considered for sensitized patients, but should take into account patient characteristics, antibody attributes, and their biological significance. Meaning, do you have antibodies that are many in the ability to bind complement, for example? So crossing DSA, not for everybody, but to think about it as well. Treatment considerations for the sensitized patients at transplant. Many of us will use induction therapy. About half the group thought that induction therapy, ATG or basileucimab, may be considered perioperatively for these sensitized patients. There are some anecdotal reports that indeed these agents may actually decrease production of antibodies and maybe AMR at the same time. If crossing DSA at the time of heart transplant, induction therapy, or IVIG, plasmapheresis are common therapies to give perioperatively as well. If in experienced centers, the addition of complement blockade given perioperatively in highly sensitized patients may be considered when crossing DSA with MFIs, let's say greater than 10,000. We have done that, and we do that, and I'll talk about that when we talk about our complement blockade strategies with the use of eculizumab. The approach to post-transplant DSA, several variables should be considered to treat these patients with post-transplant DSA. And a lot of this has to do with, clinical presentation, either patients having cardiac dysfunction. When you do a biopsy on these patients, you see, antibody-mediated rejection, and maybe even using the molecular microscope to look at intragraph mRNA transcripts that may suggest that you've got antibody-mediated rejection that is present. So, all of these are adjunct, to the DSA that one sees post-transplant. And also, the participants felt that a biopsy was not mandated in patients with asymptomatic post-transplant DSA, but should be performed when donor-specific antibodies are associated with clinical signs of graft dysfunction. And the clinical utility of treating asymptomatic post-transplant DSA has remained unclear. Let me just state that, to begin with. We have been treating such patients if the antibodies have the ability to bind complement. And I'll talk a little bit more about that. And this is the final consideration. Testing and treatment of non-HLA antibodies have not been recommended until a causal role in graft injury and defined thresholds are established. There's still not enough data there for causality of non-HLA antibodies. Sensitization to be factored into donor heart allocation policy, like you do in Canada. And we don't do that in the US, but I believe we will be doing that in the sense when we look at continuous distribution, and standardization of HLA laboratory assays and reporting is needed. So more to come in terms of our transplantation roles per se. So let me move on to the current desensitization strategies. I took this slide from Marlene Habel, and this really points out what we do for our sensitized patients. If you look on the left, and the figure on the left, you have a dendritic cell, monocytes, and they do activate T cells, T follicular cells, to cause the B cells to become activated, and they turn into plasma cells, and plasma cells make antibodies as you move up the pyramid. And you can see the drugs that are used to block at the various points. ATG can block these T cells, follicular T cells, from perhaps activating the B cells or activating the natural killer cells that are also involved in ABMR as well. Rituximab, and obinutuzumab can block B cells, the anti-CD20. The proteasome inhibitors like bortezomib or carfilzomib block the plasma cells. Now they have the anti-CD38 with the daratumumab, and then antibodies, plasmapheresis, IVIG, and of course, IDIS, which is inflammases. These are newer agents that I'll briefly discuss as well. And you can see from our consensus conference, you can see that most programs, when they do have desensitization issues, the two big ones are IVIG and plasmapheresis. You can see the other agents are being used much less likely. And I show you this slide. It's a busy slide, but it just goes from left to right. You have your naive CD4 T cell that helps with the follicular cell, activate the naive B cell to the IL-6 producing plasmablast that turns into the plasma cell and makes antibodies. And you can see in the gray boxes, and I won't go into them in all detail, it shows you where various drugs, can block this pathway. And so it's not uncommon to use a combination of multimodality, if you will, in terms of therapies to try to block these antibody responses. And to the far right is your complement blockade, either with the Berinert, which is C1 esterase inhibitor of the C1, or the anti-CD5 or C5, which is eculizumab in that light as well. But many areas which does make sense in terms of our therapies for desensitization. This is what we do at Cedars. For listing patients for transplantation, we measure the PRA. If a strong binding antibody or CPRA greater than 50%, we'll consider desensitization. We'll remeasure every 6 months and 2 weeks after sensitizing events, like blood transfusions, for example. We divided up into severity of illness, status 1 and 2. We'll consider perioperative desensitization with eculizumab, plasmapheresis, IVIG, and again, you see eculizumab there. And these are for urgent status ones that don't have time to wait. We really wanted to get the antibodies down where we know we will cross high level, DSA. But we will do a prospective cross-match and CDC cross-match in those patients. Status 3, we have more time. We'll consider plasmapheresis and bortezomib in that situation. Status 4 to 6, so we'll consider IVIG, obinutuzumab, or rituximab in that situation. And for refractory antibodies, everything else, carfilzomib, tocilizumab, we now use daratumumab, and of course, eculizumab at the same time. Now, these are the treatments of the sensitized patients and current concepts that we use. Elimination of circulating antibodies with plasmapheresis, inhibition of residual antibodies with IVIG, suppression of B cells with rituximab, obinutuzumab. And obinutuzumab is a humanized form of rituximab. That's where we find it to be actually more powerful in that sense. Suppression of plasma cells, bortezomib, carfilzomib, daratumumab, binding of complement with eculizumab. Many of us have started to use belatacept, co-stimulation blockade, and I'll talk briefly about that as well. And I show you this just for a desensitization protocol. This we started, more than a decade ago, and we still use it actually because it's been very helpful using IVIG and rituximab, which we start after 1 week after giving IVIG, and we give the IVIG on day 1 and day 30. And we follow up antibodies on day 22 and day 44 of this therapy. We've been very fortunate. We see a lot of decrease in antibodies, and these are first pass. These are ones that they're not highly sensitized, mostly between 50 and 70, 80%. And you can see we can drop antibodies quite nicely in those patients. Now, what about the patients who are in-house, hospitalized patients? We use bortezomib in those situations, and you can see here, we give bortezomib 1.3 mg per meter squared. And let me get right to the next slide, because this will be the telltale slide here. We do plasmapheresis on Monday, Tuesday, and give the bortezomib Tuesday afternoon. Wednesday will be a rest day. Thursday, Friday, plasmapheresis. Give the bortezomib on Friday. Weekend is clear, and then we repeat the process. And it works quite well in this situation. Many of these patients have already received rituximab or obinutuzumab. And even so, we are able to basically knock down antibodies in this situation as well. So we find it to be very helpful. Now, more recently, we've been turning to daratumumab in solid organ transplantation. And why? Because we want to get rid of the plasma cells, and we kind of shy away from the rituximab and the obinutuzumab. And why do we do that? Well, because we know that these patients may be up for transplant soon, and they're broadly sensitized. We know we're going to need a prospective crossmatch. And if you do a CDC prospective crossmatch, and you have patients, recently receiving rituximab or obinutuzumab, your class 2 is going to show killing. And you're not going to really know whether or not that's because of the antibodies or because of the rituximab or obinutuzumab. And that's why we've been really, embracing daratumumab. It depletes plasma cells, the anti-CD38, depletion of immunosuppressive cells, including regulatory cells here. That's why you see that blockade. So it's that question mark, is that bad for transplantation? But it does knock down antibodies. And, in our hands, and my colleague, San Jordan, we've seen some really decrease in antibodies. You can see here, pre-DARA in red, post-DARA in blue, where we knock down various antibodies here, quite significantly so. This is the protocol that we use. We initiate plasmapheresis for 5 days. Then we give the daratumumab. We give IVIG, and then we give daratumumab. 1 week after the IVIG, there may be some drug-drug interactions there. So we start about a week afterwards. And we do it weekly for 4 weeks. And then we check antibodies. And then if we still see antibodies there, then we'll do another 4 weeks. So we'll do up to 8 weeks of therapy. But usually the first 4 are quite evident in what we need to knock down these antibodies. So stay tuned, more to follow on that as well. And the pediatric group has seen a lot of good response to that as well. Now, in this slide here, I show prevention of complement activation. Now, despite existing desensitization therapies, many patients demonstrate elevated levels of antibodies, which represent a barrier to transplant. And complement inhibition may allow these highly sensitized patients to successfully undergo heart transplant. And eculizumab is a potentially promising agent, which through the terminal complement inhibition may allow transplantation to occur. And so that's why we used this eculizumab for these highly sensitized patients, believing that, we can prevent any hyperacute rejection or delayed hyperacute rejection, and maybe even foster a decrease in antibodies over the course of time. And so we developed this protocol where we would give eculizumab early on at the time of transplant. At the release of the cross clamp is when we give the first dose of eculizumab, and then we give it at various points in time for 2 months. So 8 weeks of therapy. And so we put together this trial called the DUET trial, de novo use of eculizumab in highly sensitized patients undergoing cardiac transplantation. Hence, we call it the DUET trial. And interestingly, too, we needed a control group. So our colleagues in France, and with Guillaume Coustance, offered his patients along with Alexander Lupi from the Paris group. And as it turns out, they have just as highly sensitized patients as we do. And so they use a combination of PLEX, plasmapheresis, IVIG, ATG, and that's what they do for the Paris group. Now, for our highly sensitized patients, we had 20 patients who are highly sensitized. And as a primary endpoint, we use AMR greater than PMR grade 2 or greater, and or left ventricular dysfunction, meaning ejection fraction less than 40%, less than or equal to 40%. The CPRA, average CPRA was 96% in this group, so highly sensitized. The immunodominant DSA was MFI 6,250, and some were much higher in the 10,000 plus range. And we use flow cytotoxic crossmatch as well. So the B cells, many of them were positive. And then the T cells, 58% were positive. So what we did mandate, though, we mandated that we have a negative CDC crossmatch. But you can see that the flow crossmatches were high, were quite significant as well. And I'll get into that too in terms of what is a significant flow crossmatch, flow cytometry crossmatch in the face of a negative CDC crossmatch. When is too much in terms of the flow cytometry, because that is important as well. Okay, so in terms of demographics, you can see the demographics were pretty much the same. The only thing I underlined here was that the CPRA transplant, the CPRA of 5,000 was our threshold, 95% in the eculizumab group, our Cedars group, 74% CPRA in the Paris group with the same threshold at 5,000 MFI. And so what did we find? All right. When we looked at the panel A with the left upper corner, the incidence of the primary endpoint, AMR greater than PAMR2 or greater, and LV dysfunction, the same between the two groups. In B, survival between the two groups, the same. But look at this. It's in panel C. Cumulative incidence of biopsy-proven antibody-mediated rejection was significantly higher in the Paris group, meaning without eculizumab, and while giving eculizumab, we were able to knock down that antibody-mediated rejection on endomyocardial biopsy. And when you looked at the number of biopsy-proven AMR per patient in panel D, you can see the light gray as weight goes out to like 4 and greater than 5. So yeah, these patients in the Paris group were having repeated episodes of antibody-mediated rejection when we were able to limit it to either 0, or 1 or 2 at the most antibody-mediated rejections on the biopsy. And some of them did require treatment. None of them were hemodynamic compromised. So yes, we did intervene with steroids sometimes and maybe rituximab, but we were able to turn that around quite easily, quite readily. We took it a step further. Our colleagues in France with Guillaume Constance did some nice studies looking at major AMR-related pathogenesis-based transcripts, basically looking at intrograph mRNA transcripts to see what would be activated in these patients. We looked at endothelial donor-specific antibody selective transcripts, injury repair response transcripts, and quantitative constitutive macrophage-associated transcripts. And you can see them here, the left-hand corner. In each one of these panels, you can see that the eculizumab group had significantly less, activation of these AMR-related pathogenesis-based transcripts. So really looking at mechanistic processes, and it seems like the eculizumab-treated patients really did have an impact knocking down the mechanisms here as well. Now, we took this one step further and we looked at time post-transplant in terms of these molecular score when we combined all of these transcripts together. And you can see the eculizumab is on the left, the standard of care is on the right, meaning the Paris group. And when you look at 1 month, 2 months, 12 months out, yeah, we still were able to knock down, these transcripts, in terms of biopsies performed at those periods of time post-transplant. So it really looks like the eculizumab, although it's given only for 8 weeks, really had an impact continuing on, effects, or setting the table for less immune activity, even up to 12 months post-transplant, at least in our study group here. So more to come on this as well, but we're pretty excited about this result as well. Now, so from the DUET summary, we summarize that eculizumab administered to de novo heart transplant recipients with CPRA greater than 70%, with a CPRA actually average in the 90% range, was associated with 90% survival at 1 year, as well as significantly less biopsy-proven AMR compared to the Paris group, or what we call our control. Eculizumab appears to be well tolerated and associated with a low rate of infection. We had less than 50% of our patients had any type of infection, which does correlate to our non-sensitized group of patients as well. And we're talking about, urinary tract infections included. Further studies are needed to confirm these preliminary results and determine effects and the development of cardiac allograft vasculopathy. Yes, we'll have to look at, 5 years, 10 years down the line, and hopefully we'll have an impact there as well. And we believe we may at that point in time as well. I'm going to end with some topics that I think are important because these are special issues that arise in terms of our sensitized patients. I'll talk about the approach to sensitized mechanical circulatory support, MCS device patients. We know that they have a higher prevalence of having antibodies. Why? Because they get a lot of blood transfusions. And it's said that up to 30% of MCS patients are sensitized. Not all highly sensitized, but a certain number of them certainly are. And we'll ask the question, does crossing donor-specific antibody at the time of transplant make sense? And what about if you transplant against high MFI donor-specific antibody? All right, and we'll take that again even further. Does crossing multiple donor-specific antibodies at heart transplant, what is the outcome for that? And we looked at our patient population, and I'll show you data on that. And what about tocilizumab for these highly sensitized patients? Does it work? This is something that many of us have been trying to use as well. And there's something really exciting. What about the bispecific T-cell engagers? Teclistamab, we have started using that as well. And the kidneys have a clinical trial using this drug as well. And we'll talk about that. Well, let me get right to our sensitized MCS patients. So among 889 consecutively enrolled patients who underwent transplant between 2010 and 2018, 275 patients were sensitized. Now, we grouped these patients essentially into those that were sensitized VAD patients and sensitized non-VAD patients, okay? You see group A is the sensitized MCS patients, group B is the sensitized non-MCS patients, and group C and D are the controls. Basically, they're not sensitized at all, but MCS patients non-sensitized and non-sensitized patients without LVAD. So C and D you view as being your control. So when you look at primary graft dysfunction, there was a trend, but it was not significant in terms of perhaps more of the sensitized patients having more PGD, and that's been borne out by other studies as well. 1 year survival, freedom from CAV, 1 year freedom from non-fatal major adverse cardiac events, from ATR, any treated rejection, ACR, freedom from 1 year ACR. No real difference, significant difference between the two. But when you look at 1 year freedom from antibody-mediated rejection, there was a significant difference. And that is that group B, sensitized non-MCS patients, so no VAD, they had a lower freedom from AMR compared to all the other groups, including sensitized VAD patients. Now, why should that be? Well, you look at the sensitized VAD patients, 95% had 1 year freedom from AMR. That was the same as the control groups, without sensitization, 96%, 96%. So, and these are large numbers. In the sensitized VAD group, you had 86 patients here. Controlled to the other several groups. So there's something going on here. So then we looked at the Kaplan-Meier curve for freedom from AMR for sensitized MCS patients and sensitized non-MCS patients. So they're both sensitized. Look at this. The sensitized MCS, much greater freedom from AMR compared to the control groups. When we actually looked at the antibodies, we saw the antibodies drop precipitously with the sensitized VAD patients. So when you take out the VAD, something goes on. You knock down inflammation, so we see them. So we concluded here in summary that sensitized MCS patients showed a comparable 1 year clinical outcome to non-sensitized patients in consecutively enrolled patients. When compared with sensitized non-MCS patients, the sensitized MCS patients showed less first-year AMR. And again, this is conjecture, of course, but removal of the MCS device at the time of transplant with rapidly following antibody detection might be related to a lower incidence of antibody-mediated rejection. And that's what we see. That's what we believe. And why does it matter? Because we don't treat these patients very aggressively, knowing that we're going to take out the VAD and knowing or realizing that the antibodies are going to dive down and we're going to see far less antibody-mediated rejection. In fact, no different from non-sensitized patients. So pretty cool in terms of something that we view as not being as significant as others. All right. So the big question was, does crossing DSA at the time of heart transplant make sense? Maybe. In this group here, patients were subgrouped into those patients with low, MFI, and I'll go to that in the next slide. But here we just use DSA that would cross and DSA not cross. And yes, you look at 3-year survival in this case, 3-year freedom from CAV, 3-year freedom from non-fatal MACE, left ventricular dysfunction, acute cellular rejection. There's no difference between the two. But yes, when you cross DSA, you might expect to see more antibody-mediated rejection by biopsy, and that's what we do see. But as you can see, it doesn't impact outcome, in terms of heart outcome, survival, freedom from CAV, et cetera. So it's quite interesting that you can cross this DSA. Now, what about the level of DSA? Now here we show we cross low DSA, medium level DSA, and we coined this in terms of low level DSA less than 5,000, medium 5 to 10,000, high level 10 to 15,000, and very high level greater than 15,000 MFI. And again, we mandated that these high level patients had a negative CDC prospective crossmatch. So we're not going to go into hyperacute rejection here, but certainly we can see delayed hyperacute. So that's why we do give eculizumab for that very highly sensitized group there as well. You look at freedom from AMR. Yeah, as you go to higher and higher levels of DSA, yeah, you see more AMR in these patients. But again, it did not impact outcome. I just showed the same data up there. When you look at survival, 3-year survival, freedom from CAV, non-fatal major adverse cardiac events, made no impact. So yes, we basically tolerate, the ABMR. Will it hurt us 5 years, from hence 10 years? We'll have to wait and see. But maybe the therapies we're using, because we do use ATG after everybody, followed by IVIG when we cross DSA. What about multiple specific donor-specific antibodies? So we try to look at everything down the line because, yeah, we end up crossing not only one, not only two, three DSA, 4 or more DSA, and there are combinations, some are high level, some are moderate and weak. And then we compare it to no DSA being crossed. And again, when you look at outcomes here, 3-year survival, freedom from from CAV, non-fatal MACE, it's the same amongst the groups, all right? And the 1-year freedom from AMR, again, it's going to be, you're going to see more AMR, but again, it did not impact survival, even when we cross 4 or more DSA. Again, mandating a prospective CDC crossmatch. Again, following that with, ATG 1.5 mg per kg for 5 days, then followed by IVIG 1 gram per kilo daily times 2 days, and then we follow these patients out. If we start to see antibodies rise, we may consider, depending on the antibodies, give obinutuzumab and IVIG at that point in time. And we haven't really gone beyond that. They respond quite nicely to these patients. And again, some of them are receiving eculizumab for that highly, highly sensitized group, as I mentioned before. And I show you this tocilizumab that we've been using more and more. If you, and these are the 7 patients that the early patients that we used it on. When you look at the middle row, the middle column, change in MFI, you'll see that we did knock down MFIs quite readily in all these patients. And you see a 0 there for the number 2 patient. Well, to tell you the truth, we probably knocked that down too, because our assay would only go up to 17,500. So it's greater than 17,500. So we may have been like at 25,000, maybe we came down to 21,000, but it still would show just greater than 17,500. So that's why I say we're probably very successful in knocking down, MFIs. But when you look at change in PRA, in 4 of the 7, we did see a change in PRA. Why? Because you can knock down, MFIs, but if you don't knock it down enough to get, outside a certain range for, C1q binding or, your dilution assay, you may not see a change in your PRA per se. But the fact that that tocilizumab was effective and did knock down antibodies gives us some pause to continue this for certain patients. 1-year survival, you can see, was great in this patient population. Freedom from AMR also was very good in this patient population as well. I'll end with this slide here. This is a bispecific therapy for treatment of multiple myeloma. We've treated one of our patients already. We'll have to see how it does work out. And I know the kidneys with Stan Jordan in our program, and for the kidneys, they've started a trial using this. And this is a really interesting therapy. The mechanism of action is bispecific. Basically, this is an antibody that will bind to the CD3 T cell. Okay. And then the other arm will bind to the plasma cell and to the B cell maturation antigen on the plasma cell. So it's bringing your T cell and your plasma cell together, and that's causing cell death. So it's really pretty cool how that works. When you talk to our our hematologists, it works wonders, to really knock down antibody production. And at least preliminary in Stan's hands, that has had good results. We'll see in our hands as well, and we do have a protocol where we have 12 patients in the waiting to receive this therapy, highly sensitized patients. So with that in mind, this is a summary. Effective treatment with plasmapheresis, IVIG, Rituximab, bortezomib have been effective to lower circulating antibodies, but the optimal regimen has yet to be established. Crossing DSA at transplant in specific populations appear to have acceptable post-transplant outcomes, but you will see antibody-mediated rejection. Specialized perioperative and post-transplant care for highly sensitized patients may be needed to optimize outcome. In our example is eculizumab, and there are promising drugs currently in study, daratumumab, tocilizumab, belatacept, that may be more effective in this approach and management of sensitized patients awaiting solid organ transplantation. Maybe the bispecifics will come on as well. And with that in mind, I'd like to thank you for your attention.
Thank you. Thank you so much for this excellent presentation and also for your many contributions to the field that will help us not to have as many evidence level C and May recommendations in future consensus conferences, hopefully. Please raise your hands and put your questions in the chat. I'll still use the opportunity to ask the first question. I'm a bit surprised about the eculizumab that early in the cascade, because as you block your complement activation, you basically deactivate your ATG function in part, your daratumumab, your rituximab, and so on. And also you won't give the same protection from infections when you give IVIG by knocking out the complement activation. Have you seen that in practice to be a concern, so that your other maybe drugs that you may want to use don't work as effectively anymore, or is that a theoretical concern?
Yeah, and that is why we actually looked at the these transcripts. So we do know that we knock down these pathways, and that and maybe it seemed to even though we gave ATG at the same time, it seemed not to to knock that out in its entirety. So we believe that we did get some protection from that as well, and then followed by IVIG. So yeah, there were so many potential drug interactions that we had here, but at the same time we made sure that we were doing something, and hence we do take a look at the mechanistic aspects of this as well. It's quite interesting though too that now we don't use the eculizumab for everybody. What we've done now is we're now looking at the CDC crossmatch or prospective crossmatch, and now we're looking at the flow cytometry. And if the flow cytometry shows us a median channel shift of less than 200 MCS, then we feel confident we don't need the eculizumab, and that we can actually do it alone with ATG and IVIG. And that's being borne out now too by some of our recent work as well. So there's more to come on that because there are some interactions that we didn't want to see, but again we felt we were getting a good response just from the whole with giving all these drugs.
Fantastic. I have a couple of questions in the chat before I get to Kieran, sorry. So one is from Evan Atkinson, two questions. One is about MFI cutoffs. How do you adjust if you have a DSA that dilutes over 5 or 10 or 20 beads? And do you use any alternative single antigen bead providers in these situations?
No, we use I'm not quite savvy as to which provider we do use, but I mean it's standardized within our HLA laboratory. I'll have to ask Sam Zhang about that. Yeah, we do shift around our threshold depending on what we see in terms of our antibodies. When we have highly sensitized patients, yeah, we'll move to just avoid greater than 10,000 MFI, and realizing that the undiluted specimens really don't correlate really well with outcome. We have now gone to the 1-to-8 dilution, and so if we may avoid only those in the dilution assay, and knowing that we will cross maybe higher levels of DSA in the undiluted specimen. But if they don't show up in the diluted, specimen, that just suggests to us that they're really not that important. And so we can, so-called get away with just ATG and IVIG rather than to go with eculizumab because of that high level. And so even in my talk here, we kind of are morphing into, better understanding of what is happening in terms of the high levels of DSA and whether or not they are meaningful or not.
Thank you, Kieran.
Well, thanks, Simon. John, thanks for this. This is a great talk. I'm Kieran Haller, and I'm from the lung program here. We published a similar work just from our center, looking at a very similar question, very similar regimen, and we kind of concluded it was safe. I'll put the link in the chat. But the one of the things we saw too was an increase in what we thought was AMR after transplant as well in this cohort. But one I thought an effect we were actually seeing was, you probably know our AMR diagnosis sucks, for lack of a better term. It's very, very poor sort of clinical surrogates. And so one thing I think we thought we were seeing, we didn't see higher rejection rates overall. But when rejection happened, I think the clinicians were more likely to call it antibody-mediated rejection because we knew the patient was DSA positive. Do you think that effect could be operating in your cohort, or are you fairly confident these cases were fairly rigorously phenotyped as antibody-mediated rejection?
Yeah, and that might be why, let me, first of all, when we gave eculizumab, what we did notice is that we had more C4D staining. And, we're blocking at the C5 level. So, not unexpectedly, we may see more, backup of C4D because we're blocking at the C5 level. And so theoretically, that, could be the case. And that's why, and perhaps why, these antibody-mediated rejection episodes may not be actually real. Yes, they were AMR2. So maybe there was endothelial cell swelling, but just maybe that C4D was not real, because of the eculizumab and the increase in C4D, and that's why we believe that the transcripts were very helpful, that suggesting that maybe these ABMR that we see were probably overcalls and not necessarily true ABMR. And that may be why they're less virulent, why they're not really leading to, to bad outcomes at least 3-year mark, and we'll get to the 5-year mark pretty soon on our patient population. But that's with ABMR, even from from the molecular microscope. We're not seeing a lot of aftermath in terms of complications. Just seeing ABMR even on mRNA transcripts. So similar to what we're seeing here as well. So we'll have to see correlations.
Thank you.
Apologies, we'll probably not get to all the questions. I want to take one more question here from the chat with interesting hypothesis. So one, it says, what is an acceptable outcome in the long run? But particularly the question is around, could HLA antibodies be cross-reactive or reflection of polyreactive viral antibodies. Along those lines, I was wondering, in your VAT group, do you think quite a few of those VAT patients had passively transfused antibodies that actually didn't reflect because they responded so well to your desensitization strategies? Any comments?
Yeah, that's always a possibility. But a lot of these antibodies were there for extended periods of time. We draw their antibodies every 6 months. And many of them are on the VAD for a while. Before they get transplanted. So just the nature of our allocation system. So I think that these are real entities as opposed to passive. So it's something that we do. We do believe that removing the VAD, and we know too, the VAD does have inflammatory reactions, and that's been studied through and through as well. So we're convinced that there is an additive inflammatory response.
And you do not believe that all HLA antibodies are just cross-reactivities to viral antibodies?
Well, that we haven't looked at, so I couldn't answer that question. Yeah, but we see in our cohort we've seen a variety of antibodies that do decrease, and it is literally all of them decrease quite precipitously. I didn't show that slide, but it's like wham. I mean, you see a big drop quickly over the first 1 to 2 months, and it's quite dramatic.
Fantastic. Thank you so much for your excellent presentation, answer to the questions. If you were not able to get an answer to your question, please feel free to email them to to Sean Delaney or me, and then we'll pass them on to Dr. Kobashigawa for his kind response if he's willing. And thanks for attending. Come to the research day, and we'll see if there is a seminar next week.
Yeah. Thank you so much, everybody.
Thank you, John. This is fantastic.
Okay, thank you. Bye, Phil.